Mohta. I'm going to give you a glimpse of our article on effect of timing of intraoperative administration of paracetamol on postoperative shivering. Postoperative shivering after GA is a very common problem. One of the mechanisms responsible for this is increase in core body temperature set point in postoperative period. IV PCM acts through centrally mediated prostaglandin inhibition and decreases hypothalamic temperature set point, thus having an anti-shivering effect. However, we must understand that PCM can decrease body temperature even in the absence of fever and can exacerbate perioperative hypothermia in patients whose body temperature is not strictly maintained in the normal range. Thus, PCM has an anti-shivering effect, but it can reduce its own efficacy by causing hypothermia when administered before surgery. So this study tried to compare different timings of IV PCM administration. The primary objective was to compare the incidence of postoperative shivering, whereas secondary objectives included comparison of incidence of perioperative hypothermia defined as the core body temperature less than 36 degrees centigrade, time to analgesic requirement, and any postoperative complications. This was a randomized double-blind controlled trial in which 225 ASA 1 and 2 adult patients of either sex undergoing elective surgical procedures performed under GA with expected duration of surgery between 1 and 4 hours were included. There were 3 groups. In early PCM group, PCM was administered in a dose of 15 mg per kg up to a maximum of 1 gram immediately after induction of anesthesia. Whereas in late PCM group, the same dose of PCM was given approximately 30 minutes before completion of surgery. Control group patients received only normal saline and no PCM. The core body temperature was measured using infrared tympanic membrane thermometer at different time points. All the patients were covered with forced air warmer intraoperatively and a single blanket postoperatively. They were observed for shivering, pain, and other postoperative complications. Shivering was graded from 0 to 4, and grades 3 and 4 shivering episodes were treated with IV tramadol 1 milligram per kg. We found that the overall incidence of shivering as well as shivering episodes requiring treatment were significantly lower in late PCM group than the other 2 groups. And the other groups, that is early PCM group and control group, did not differ from each other significantly. Also, the incidence of postoperative hypothermia was significantly lower in late PCM group, and the time to analgesic requirement was also longer in this group. So now, how do we explain our results? The onset of anti-shivering action of PCM is almost similar to that of its analgesic action. But the peak hypothermic action occurs at about 120 minutes. So when PCM was administered early, that is immediately after induction of anesthesia, then its anti-shivering effect must have been present, but its hypothermic action along with anesthesia-induced hypothermia and other factors like OT temperature and surgery-related factors, so all these would have combined and resulted in hypothermia, and therefore the incidence of shivering was much higher in this group. Now, when PCM was administered late, that is towards completion of surgery, its analgesic and anti-shivering actions, they came into effect without any significant hypothermic effect, thus resulting in a lower incidence of hypothermia and shivering. So to conclude, administration of IV PCM 30 minutes before completion of surgery resulted in a lower incidence of postoperative shivering and hypothermia and provided a better analgesic effect than administration of PCM after induction of anesthesia or no PCM. All of us administer PCM to our patients, and it is a routine. But according to the results of this study, it would be better to administer PCM towards the end of surgery to have the best possible results. Thank you.